Oh, there we go, and good afternoon, CNY Nation. I'm talking to you live from Colorado Springs, and I'm Dr. Randy Fink from CNY Fertility in Colorado, and also from the evolving CNY Fertility at the Miami Center of Excellence in Florida. And of course, joining me from Syracuse is the one, is the only, Dr. Robert Kiltz and his cup of coffee. Dr. Kiltz, good day, sir.
A good day, and thank you for joining from Colorado, Dr. Fink. A pleasure, always great. We already have Sherlyn, Jessica, and Kelly on, so hello. Oh my gosh. They're joining us. We're so appreciative.
Kiana, that's a pretty name. And Jillian, we've got Dee. Good afternoon to you guys. Yalitza, so happy to have everybody with us today. And so, we call these Thursday afternoon things conversation. Oh, yes, Amber, and I did enjoy the cupcake. I just have to give a shout out here to Amber, who was in the office here today and brought the most fabulous cupcakes. And she says, and you can have one as long as you're not married to keto. And I said, I'm going to have a cupcake because everyone's entitled to a reward.
Right? From time to time. But remember, the variety and spice your wife will not like.
That's a very good point. And hi to Tiffany and Felicia, Jessica. Yes, I am doing retrievals here in Colorado. Idalia and Amber. So, we'd like to talk about, this is your time, you guys, to talk about fertility things, talk about whatever's on your mind. Good things always to talk about if what always comes down to things that are important in our lives as it pertains to fertility, keto and inflammation, because those are very real parts to our lives, and it's something that we can do something about just simply by focusing on what goes in our mouths. So, I think that's important stuff. Let's start with Amber. Amber is starting her IVF. I guess that means her stim at the end of March. She is 29 with an AMH, or an ovarian reserve test of 1.94, and is asking really about, she's got a couple of interesting points here, a dosage, and she's starting with a dosage of 300. So, that dosing thing is a big mystery to a lot of people. And Dr. Kiltz has some really important ideas about dosing, and so why don't you talk to us a little bit about that and on new kind of lower dose ideas.
Well, I think our standard dose for years was at the 300 level, and then quite commonly we do a 450 to 600, but more and more we're working to the lower dosing, and I call it the mini dose. And I think the real sweet spot, especially for 29, is a combination of letrozole 10, gonal or follicle 200, and HCG 20, because now you're less likely to overstimulate, although we do see a few younger women or at any age, and we say younger, the AMH is that's a 2 AMH, which is pretty decent. I love the lower doses because, again, you're not going to overstimulate as well as likely, and you're more likely to get that fresh transfer. So 10, 220, 10 of letrozole, 200 of gonal or follicle, and 20 of HCG, or the 150 and 75, 150 of gonal or follicle and 75 of Minipure. Again, with that letrozole, I think is really helpful. Reduce sort of the total push on the ovary, keep the estrogen, progesterone levels down. It's my sweet spot that I think more and more for women with lower AMHs, those that are called DOR, and we've even looking more and more towards natural cycles, where for some people who have even lower AMHs, less than 0.5, may do fine with just a natural cycle.
But there's certainly nothing wrong with Amber's 300 dose.
No, I don't think so. I think it's okay, but again, I typically like to go to the lower doses.
Now, she is shooting for a day 5 fresh. Why don't you talk a little bit about fresh versus frozen transfers, because that is often, and it's interesting because people tell us what your thoughts are on fresh versus frozen.
Well, I love both. I think, hold on one second. I gotta take care of. So it's never stopping work, no matter what. And one of the nurses is like, "Where are you?" But I think fresh and frozens both work great. If you have higher progesterone levels over 2.5, and higher estrogen levels more than 3,500 to 4,000, then doing a freeze all makes a little bit more sense. But we have some people that even with a little higher estrogen progesterones do fine with the fresh transfer, either a day 3 cleavage stage, and we do day 2, 3, and 4 as cleavage, and day 5, 6, and 7 as a blast, mostly 5 or day 6s. But if you're doing duo stims or triple stims, or you're doing any PGS testing, embryo biopsy for any reason, then you'll want to do a freeze all. But again, I think they're nearly equal in this process, so you don't have to always do one or always do the other. Be open to all of them.
Okay, hopefully that helps, Amber. Tessie, we're glad to have you. And hi, Marie from Central Florida. We've got Shannon in Kansas, and let's see, we've got Kelly in Ohio, and Marie's asking about Atlanta's services. What's happening in Atlanta now?
Well, Atlanta is working towards transfer retrievals later in the year. Dr. V's doing awesome in Syracuse. Right now it's consultations, ultrasound, and blood work. It's monitoring and any biopsies or PRP or lipids. And nowadays we're doing all of our consults and follow-ups all virtual, either video or phone. So it really makes it nice. But Atlanta, working on Atlanta later in the year. We just got Buffalo rocking and rolling. We're just open up in Colorado. It's been, about 8 to 9 months now. So really excited. Dr. Fink there now. And then we're working on Sarasota. But Atlanta, later in the year, everyone's patience in the process. We're going to get you there.
Hi to D'Angela out there, who asked a great question, about CoQ10. She is on oral CoQ10 now before retrieval with an AMH of 0.35, and she's worried about egg quality. What's the relationship between CoQ10 and egg quality? And she's actually also asking about intramuscular injections.
Well, I don't know that I can answer that about IM injections on CoQ10 and topicals and other methods. I do know that the antioxidants and CoQ10 is very critical in the normal metabolic pathways and reducing inflammation, and vitamin D, hormone metabolism. So it's all very critical. And, the key to a healthy lifestyle and a fertile lifestyle, we use the term keto, by the way, but I would say it's the key to your fertility. It's all anti-inflammatory, and no matter what you choose to eat, we want to get inflammation down. And I've seen with a dietary change of one meal a day, one snack at the most, high fat, that's keto, by the way. Whether you're a vegan or vegetarian or a carnivarian, by reducing inflammation, I've seen AMHs come up. So this is where we use our vitamin D, our CoQ10, fish oil, but it's adding fat is critical, along with DHEA, our ovarian bloom supplement. I think can be very helpful, and you should be able to get it right from our website. Molecular fertility, ovarian bloom can be really, really helpful. Besides acupuncture, massage, and slow it down, that's really, really, really critical. And certainly our prayers go out to all those that have lost lives in Atlanta, the Asian massage therapists, and our love to the families, and our prayers are really out there for everyone. So this is a tragedy that's happened, but we're all going to do our very best to continue to have faith and be persistent in doing better.
And hi to Tabitha, who is asking about varicocele. So for those who don't know what a varicocele is, that's a problem in the male. It's a series of dilated blood vessels around the testicle that can result in sperm issues and male factor infertility. So Tabitha is asking, are varicoceles always recommended to be treated?
Well, varicoceles in and around the testicles are indications of inflammation. And so you don't necessarily need to treat the varicocele by ligating it, or there's a radiologic obstruction that can be done. But it's an indication that you got something going on. Even with normal sperm parameters, I believe there's some hidden things like DNA fragmentation or morphology that can be factors. But there is evidence that doing a varicolectomy or embolization may be helpful. But I always like to start with, what can the guy do to reduce inflammation? Stop pounding weights too much, because that builds intra-abdominal pelvic pressure that's put inflammation on the blood flow back to the heart, along with too much exercise that heats up the core. There's evidence that using the snowballs, which is a pack, an ice pack, to cool the testicles can be really, really helpful. So I think those are important things that everyone should look towards, along with the male molecular fertility male supplements. And in some cases, we'll, again, acupuncture, massage, and we'll add HCG or Clomid or Letrozole for the guys, because we're treating the overall inflammatory process in order to reduce the varicoceles. Interesting, pelvic congestion syndrome for women is another vascular dilation that is indicative of inflammation in and around the ovaries and the uterus that I think needs to be evaluated, because we see that on ultrasound for women.
You talked a bit there about a natural cycle, and Kelly brought up a question. Her AMH is 0.22, almost 0.23. She's wondering if it's better to do meds and have a better chance, or a natural cycle and get only one egg. And is there a cost difference? And the cost certainly has to do with the cost of medication, right?
So higher meds, I don't do anymore, especially on DOR or diminished ovarian function or ovarian dysfunction. So this is where I certainly would either do a low dose protocol of letrozole 10, 220. You could even go lower. And we've been seeing some cases where if you're not getting a mature egg that fertilizes in a lighter stimulation, 10, 120 versus 10, 220, that's the time to look at a natural cycle, trigger early at 15 to 16 millimeters, and that may be what it takes. But whatever you can do, you want to reduce inflammation and turn the ovarian function around. We've seen it happen.
Hey, and you know what? I'm just looking here, and I want to stand up and cheer for Kiana, who I think she said she's in Atlanta. She's down 77 pounds. 77 pounds from a keto diet. Holy cow, sister! That is impressive. Congratulations on that.
And the weight loss is an indication of reduced inflammation. But what I tell everyone, the weight isn't the cause of your inflammation, what's in your belly. 2 weeks to reduce inflammation. But if you're looking to shed the pounds, use the fat, not lose the fat, because we always use fat for energy. What you want to do is stop making more fat, use it, and you'll lose it at the same time.
Shannon is triggering tomorrow and has an IUI scheduled for Saturday. And yes, as long as the follicle size, the follicle, of course, is the little egg house in the ovary. As long as that follicle is 17 to 18 millimeters. So today is Thursday, and you're planning to do it on Saturday. And you're triggering tomorrow and IUI on Saturday. How do you feel about the timing of that, Dr. K?
Well, 12, 24, and up to 36 hours for IUI. I mean, there's so many different opinions on this. And basically, sperm lasts about 72 hours in general, if it's the right environment. But this is where I'll generally say 2 IUIs can be helpful. 12 hours and 24 hours after that can be very good, but right around 24 to 36 hours is good. We typically do our retrievals at 34 to 36 hours. We get eggs, getting the sperm in there. And this is where I think either IUI plus intercourse, if you're able to do that. But we need to talk more about dual inseminations, trigger at night, insemination the next day and the day following that, I think works really nicely. But again, there's so much variation in this that there's not a rock solid answer. But if what you're doing isn't working, if you're doing it 24 to 36, add a second one early on, which can be helpful.
And if it isn't working, we'll adjust it. We know how to do that. Hey, Carly had her transfer just this afternoon in Syracuse. How awesome. So our thoughts are with you and your embryo today. So how does she know if the embryo implanted? First of all, that embryo is going to stick around inside of you for a little bit of time before the implantation. Is that right, Dr. K?
What was that? What was that last part?
About how long after the embryo goes in before you expect implantation?
Well, we don't really know that answer. It's it may be minutes, hours, or days. We know that about 7 to 10 days later, we're checking an estradiol. I'm sorry, an HCG level. Urine may pick it up also. So that's when we know implantation has happened. But I don't know that we really have any good data that we're there and watching as it begins to stick. But my bet is the sticking happens pretty quick after it's been transferred and settling in order to get going.
And so that first estradiol, progesterone, about a week later, the results that we see with that are not variable upon whether the embryo transferred. Is that correct? Or not
right.
transferred, whether the embryo implanted.
Progesterone levels don't really mimic that, but in some cases, you'll see an HCG level in some cases even that early for that middle one. And remember, those estrogen progesterone levels are quite variable. Progesterone's as low as 10 and above 40, estrogens in the 20s to 40s, but it could be in the thousands, are kind of like, hey, we like to see it about 20 of progesterone and 200 of estradiol level, but that leaves a lot of leeway, by the way.
I'm looking here to Lauren. Good afternoon, Lauren. Glad to have you with us. So on Monday, and let me see if I can get all the numbers straight here, Dr. Kiltz, so we don't confuse you. Lauren's lining was 11 millimeters on cycle day 3, and she rechecked it yesterday, and it was 13. And so she's wondering about, so I guess she's, so she's early cycle, and she's suggesting that she has a thickened endometrium, a little bit thicker of a lining than we normally see. Some have suggested a DNC or a manual cleaning of that lining, or a mowing of the grass, you might say. And some have suggested a progesterone treatment, which can also thin that lining. And she doesn't know what to do. How do you approach that problem?
Well, in general, if it's a natural cycle, we're watching a natural cycle. And I believe that some people start linings thicker and they go to the 17, 18 millimeter range and they do fine. And even some people believe the 17, 18 millimeter range is good. Sometimes we don't even know exactly what we're measuring because we don't know the part that comes off for many people. So it may be that it's completely natural and normal, yet in general, we're looking for linings less than 5 to 6 millimeters. And if there's a concern, you might have a polyp or a fibroid, that a hysteroscopy might be reasonable, a saline sonogram might be reasonable, or in some cases, this is where I start recommending either the birth control pill followed by Lupron, then or estrogen progesterone combined, then do a DNC, stop those, and go right into an estrogen prep, maybe a little low-dose letrozole in order to get the lining going. But if you have a nice triple lining, your numbers all look good, even if it started at 11 and now it's 13 to 18, you may be fine because there's such variability in all of this. But if there's a concern, it's too thick, this is where I think it's good to follow with some progesterone, maybe start some Lupron, do a hysteroscopy DNC, make sure there's nothing in there, and stay on the Lupron, and then go ahead and start your estrogen right after that. Don't wait, because too often I'm seeing people do a hysteroscopy DNC and then call with your period. Unless your progesterone if your progesterone's high, then that might be the case. But if it's low, you do the hysteroscopy DNC, and then you start your estrogen pretty quickly.
right. I think that's a great answer. Hi to Candace. By the way, for those of you just joining, Conversations with Kiltz and Fink, so glad to have you. I'm in Colorado. Dr. Kiltz is in Syracuse. And what a great day to spend some time with you guys. Thanks so much for being here. We're going to try to get to all these questions, so please forgive us if it takes a little bit. So many good questions here now. Candace asks about, something that I've heard people talk about a lot. She says, well, what's a good AMH for someone who's 33? There's not a good or a bad. Doc, talk to us about AMH.
Well, the problem with AMH, it doesn't tell us whether or not you will get pregnant or not. It's just another marker that may be more likely or less likely. Typically, AMHs above 5 may be indicative of metabolic syndrome or PCOS. And I'm going to use that may. I'm not a firm believer in that. Levels less than 1 are also questionable, that you might be leading into diminished ovarian function. So anywhere in the greater than 1 and less than 5 is probably in the normal range. But again, I do an ultrasound, I've seen low AMHs and a great number of follicles, and people make plenty of eggs. But we're also seeing a lot more younger women with very low AMHs and lower egg reserve. And I think they're the ones that can be still turned around. Ovarian PRP, uterine PRP, anti-inflammatory, ketogenic-like diets are very useful, or lifestyle. Check out my book on Amazon, Fertile Feast and Kiltz's Keto Lifestyle. You might find it helpful, but you shouldn't wait, because none of these numbers are predictive enough of tomorrow. So you can't say, gee, my AMH was 3 this month, and 6 months ago it was 6, and maybe I'm on a trend. It doesn't work that way, because we've seen it go up and down for sure.
All right, and that was also a great answer there. Misty had a cycle canceled because she had only 1 dominant follicle. That surprises me that cycle got canceled, but I suppose it can happen. She'd like to know, first of all, I'd like to know, Dr. Kiltz, your thoughts just about that. She's asking, does she need another priming month before?
Well, quite often for that single follicle, if you decide not to go to retrieval, because you still could get an egg, I would trigger it and then do a duo stem, start in 4 to 7 days later, stay on human growth, 6 units, do a mini protocol, not high dose. I'm really getting our practitioners low dose, low dose, low dose. I'm seeing too many people. They're still getting only 4 mature eggs, but they're getting 20 eggs, but only 4 mature with a standard 300 to 450. And I'm really pushing lower doses, much better. But we've seen plenty of 1 eggs, 1 embryo, and 1 baby. So it really is up to you if you want to go through that.
Ice is 40 years old and has never been pregnant, and is asking about PGS testing. What are your thoughts about? So PGS, pre-implantation genetic testing, and that gives us the ability to test embryos for certain types of chromosomal problems, to select for gender, and also to test for people who have certain types of genetic abnormalities, to select for embryos that are free of those abnormalities. But it sounds like she's asking about, well, in an advanced reproductive age woman at 40, what is your feeling about the value of pre-implantation genetic screening?
I do not recommend PGS testing for most, and certainly in the DOR group, advanced. I recommend day 3, fresh or frozen, make embryos, put them in, give them a chance to get beyond kindergarten. You cannot test a kindergartner and decide if they're going to be successful in life. There's no test in medicine that is 100% accurate. You're throwing away an embryo that might be normal, but it's tested poorly. I've seen it all day long. We do transfer abnormal embryos and get normal babies. I know it's a scary thing, but when in the last million years have we spent most of our time testing embryos? This is very new. The science, it works in sometimes, but too many women are getting no transfers, thrown out embryos, and never get a chance to get there, by the way. I'm gonna put
So,
a question up there for Megan, by the way. I've seen a
yeah.
couple of these coming up, so I want you to just not forget Megan. I've seen a couple of asking questions. So
Well, so no male factor. How long should he keep his little soldiers home before egg retrieval?
well, it's interesting because there's data that says an ejaculation every day may make better soldiers. And so this holding off for 48 to 72 hours before a semen analysis or an IUI or IVF makes no sense in the modern world. So ejaculation every day may make better sperm. So that's the amazing part to the story.
Words to live by. You heard it here first. Sherilyn is asking about, kind of what happens with the frozen cycle as it pertains to ovulation, and if that ovulation happens before a day of transfer. Talk to us just a little bit about the mechanics of a frozen embryo transfer.
Well, let's see. So we retrieve eggs and add sperm and make an embryo, and then we freeze that embryo anywhere between day 3, usually day 3, or as a blast, day 5 or 6. Day 5 or 6 in order to get the best ability to freeze that embryos. Let's wait for Dr. Fink just a minute, everyone.
Thank you. Sorry about that. The office staff was beating on the window. So, all right, go right ahead. Sorry.
All right. So basically, in order to prepare for a frozen embryo transfer, it really can be as simple as a natural cycle. And then we determine when you ovulate by either a rise in progesterone or an LH, or we see typically the follicle doesn't necessarily disappear, but we want to see some evidence that you ovulate. Check a progesterone level, or we give you a trigger shot, or you're doing a letrozole clomid trigger shot. In some cases, you might even be doing a low-dose gonadotropins in order to get a good lining. Or the most common is a combination of estrogen and then progesterone. And then we're going to be timing your transfer based on, is it a day 3 cleavage or is it a day 5 or 6 blast? Typically, we're transferring on the 4th day of progesterone for a cleavage and the 6th day of a progesterone for a blast, but that might be changed based on your ERA testing if you have one. So, there really is a lot here, but it's really it's like a standard transfer. We thaw the embryo hours before we do a transfer, make sure it still looks viable, and transfer it as we normally would. Then you continue your progesterone, your estrogen, or what other medications you're on, including immunology, immune treatments. And by the way, CNY Fertility is a center of excellence for reproductive immunology, along with fertility, by the way. So I just want everyone to know that.
Hey, let's address that, because I spend a lot of time talking with folks on the phone about immunology protocols and about how the immune system has something to do with this. So people think of us as reproductive endocrinologists. What is a reproductive immunologist, and why are they lucky that they have us?
Well, there has not been a formal fellowship for reproductive immunology, by the way. And so I've spent 20 years studying immunology and reproduction as an endocrinologist, and we absolutely practice immunology when it comes to reproduction. And we know that the cause of all disease is an inflammatory disorder. COVID is just a highlight of that one. But immunology and treatments with our protocols 1, 2, 3, or 4. And if you go to Amazon and download our family building guide, let's see, I happen to have a copy of our family building guide. You can download the digital form or the or paper copy you could have sent to you, but it has all of those protocols there. And we're looking to understand, do you have any other immunology issues? But what I found is the testing of the immune markers doesn't tell us which thing to treat you with. Just like IVF, you failed everything else, we do IVF. So we do a lot of a lot of steroids, antibiotics, aspirin, low-dose naltrexone, and of course, guess what? Keto. And then we work a lot when it comes to things like Neupogen, Plaquenil, Prograf, Humira, IVIG, Cimzia, and all these things are added, which if you failed other things, it could be very valuable.
Indeed. Let's talk about something kind of near and dear to your heart. Tessie has asked the question about tubal reversal. So, of course, women who have completed their childbearing often decide to have a tubal ligation. And that's where we can do one of two things. We can either place a clamp on the fallopian tubes, or we can cut a piece of the tube out, or sometimes even remove the entire tube. But sometimes people then decide that they would like to continue building a family for a variety of different reasons. What kind of options do patients who've had tubal ligations have?
Well, women at all ages have the right to a tubal ligation, whether they had children or not. Like a guy can have a vasectomy, whether he's had children or not. What I believe is that if they do a tubal ligation, it should be a clamp or a ring, and that's the very best way. I do not recommend removing the tubes at all, in my opinion. But in general, we do reversals. Whether you've had a clamp, a ring, a band, or they've cauterized and cut, it still can be done. We do it laparoscopically. So I think it's reasonable. If you're thinking, gee, I want to have a boy or a girl, I want one more pregnancy and that's it. IVF might be the right course, though I've seen many who have failed IVF. We did a reversal and bingo, they get pregnant. As we've seen those who had a reversal, even though they were open, didn't work, bingo, IVF seemed a thing that got them there. So I think all of those are good options.
Good deal. We've got a bunch of great questions here still pending, and we're going to try to get to all of them. But the one that just showed up on the bottom, Amber caught my eye there about a little kiltz sex ed, and that is sexual intercourse during the stim process, or is abstinence better?
Intimacy and sex is critical, no matter your gender relationship and what it is. But sperm in the vagina, in the uterus, and even IUIs pre IVF or pre frozen transfer. And I'm throwing out there as a little loose idea that it may be the thing that reduces some of the inflammation. That's kind of an interesting part to this. And sex and orgasm, again, without the sperm there, may be something to help reduce stress. And guess what happens when you reduce stress? Cortisol, epinephrine, oxytocin, serotonin. Inflammation is reduced. So we always have to keep in mind that our physicalness is critical as human beings. Touch and touch the places that give orgasms. I think we negate to talk about sex in this fertility world, but plenty of couples still are conceiving naturally after doing all of these methods and keto and reducing inflammation, a laparoscopy for endo. So you got to have sex to get pregnant.
Hey, Dr. Kiltz, why don't you, when should we stop? No, the question is, why should you stop? I think yeah, go ahead. The question is, probably has to do with about sperm concentration or semen analysis. The ideal interval to stop before needing to produce the maximum amount of sperm for fertilization.
Quality sperm seems to be better, and intercourse or ejaculation once a day seems to be something that I've seen in the literature that says it may be better. So this idea of like, we'll just hold off. Remember, we're exposing the sperm in the testicles to heat and other inflammatory particles. So, the fresh stuff, and it isn't quantity, it's quality that we're looking for in all of this.
Can you put Roseanne's question up there, Dr. Kiltz, because she's kind of has a very important thing of timing, and it's a little.
Do I have the right one there?
Yep, that's the one. That's the one. So she's a day 13 on her stem. She's going left 375, and then she stepped up to 450. So 450 and 20 of HCG with her antagonist, ganirelix, and she's on omnitrope. So one of her follicles is 37 millimeters, and she has 4 follicles on the right side, 13 to about 14 and a half. So cycle day 20 today, the nurse said she might need to cancel her cycle tomorrow. I understand that is probably a very stressful phone call to get. Maybe you could talk to Roseanne about what's happening in her cycle.
Well, sometimes I always say go slow and stay low. And sometimes you're going to sacrifice some of the bigger follicles, or you're going to trigger and or aspirate and then restart in 4 to 7 days to recruit those smaller follicles. Now, it may be, and I don't know the whole history here, that we're pushing a losing battle, but I've seen people finally respond after 30 days of stimulation. But I think it's good to give it a pause and then restart. Don't stop and say, call with your period. We need to be, you either trigger, aspirate, and then restart in about 5 to 7 days, or you look again to restart, depending on whether you have any small follicles, but the small follicles are good. You have a low LH, and there are some people that are very resistant. The low LH and FSHs with low E2s that are just have a resistant ovary, I think you need to just keep going in cases. So these are the outliers for sure, not in the standard group, but I would say that not to cancel, but to postpone. This is our problem. Oh, you got to cancel. Well, if you're going to cancel, restart a stem called a duo stem, although you're canceled that retrieval, but you're still good trigger, retrieve, or aspirate, and then go right into another cycle. Sometimes aspirating that follicle, you can trigger, aspirate just a little local in the office, not looking for an egg, and then go ahead and restart as a duo stem.
All right. Hopefully that's a help. And then come tomorrow, maybe Roseanne, you can sort of focus on the specifics of what's going on in your case. Get a real good answer. Thanks, Dr. Kiltz. That's great. Johanna's asking about. She missed we can take the question down there if you want. Thanks. Oh, it's nice to see your face again. Hey, Johanna missed her period for the first time in her life. The first time in your life you missed your period. It's a wonder people actually get pregnant. The number of things that has to go right for you to get, the number of things all have to line up for people to get their period on time. So good for you there, but you're on omnitrope and low-dose naltrexone. And the question is, do you associate either of those things with cycle abnormalities?
All of these things are related to cycle abnormalities, especially since we're watching the pot boil for sure. Much of what I think we need to start looking at is not waiting for your period, but start your meds. We'll see you back for ultrasound and blood work, even pre-menstrual cycle, to do a luteal phase stim, by the way. But, I talked to a 44-year-old who I saw 4 years ago who was starting an IVF with all these meds, didn't get her period. She got pregnant on our pre-protocol. So that could happen too. So make sure, obviously, to check a pregnancy test. But these things are all associated with what you're doing in this, unfortunately. But ultrasound and blood work, see what's going on. And then you don't need to have a period to get started on this fertility treatments. We should be doing more baselines after maybe 2 to 4 weeks of human growth, LGN, maybe even the estrogen progesterone is another good one.
You know what? I just noticed that the good Dr. Banerjee has left a note there. I guess he has joined us. Dr. Banerjee, happy to have you with us on here. And that was going back to the question about intercourse during stim, because I guess Dr. Banerjee had suggested to Amber that maybe they refrain, and he says no, but it's lots of different variations.
No, I think these are all good signs and exactly what we should be seeing. And again, we need to be more intimate in this business.
Well, Brittany has had a tough road of things here, it sounds like. She had 6 failed transfers. She had good embryos on day 5. She did all the extras, she said. She had a hysteroscopy. She had a laparoscopy. She had an ERA done. And really can't explain, just problems getting those embryos to implant. What are your thoughts?
Well, we know there's something going on related to implantation, and I'm assuming, again, it's either an egg, a sperm, an embryo. I think it's more likely in the implantation realm. This is why it's very important to look towards our immune levels for IVIG, Humira, and really a strict keto. But in some cases, it may be gestational carrier is the need. And reproductive possibilities with Melissa Brisman. We did a live last night. It's still on our Facebook, YouTube channel, so you might find some helpful stuff there, but not to give up. And I've seen failure, success, look towards coup. But in some cases, it may be we've done all the complicated immune protocols, simple. That's really it. But it sounds like you've done the majority of the work, but the antihistamine, the antimicrobial for at least 1 month. You've done the surgeries. That's good. But again, it may be simple. Do it again, and or look toward gestational carrier. And I've had times where fail. We put embryos into the patient and the carrier, and both have babies. So, this is the mysterious business. And if you look at all other healthcare areas, they're having the same problems where you think you know what you're doing and what's supposed to happen, but it's not. And we are equally frustrated on this journey. And that's why we're digging deeper and deeper to try to find the answers. But quite often you're not finding the answer why. You're doing something different in this. That's really the critical part.
Hey, let's address one here from forgive me if you pronounce it Mia, but I'm going to call you Maya. And that was has to do with empty follicles. So when we do a follicular count by ultrasound, we're looking at these places that the eggs, we believe the little egg houses. But sometimes when we go do retrieval, we find that every one of those follicles doesn't have an egg. Is there a way to ensure fewer what we'll call empty follicles?
That's one of our mysteries. So the cause of infertility is still a quagmire of unknowns in some ways. There are likely many follicles that don't have eggs, many eggs that are immature or just don't fertilize. The problem is we look at averages, recognizing that no one is an average. Everyone's a data point that's somewhere along the spectrum, right? They're anywhere in there. But one of the issues quite commonly is we might get 20 follicles, or we get 7 follicles and we get 4 eggs. And then 2 of them are mature. This is where dual stems, triple stems, lower doses, HGH, keto, laparoscopy, hysteroscopy for endo. Sherlyn brought up a point earlier. We went to a lower dose protocol, more mature, more fertilized, more blasts, and did better. So I think it's still a lot back to, quite often where our habit has always been, hit you harder, more meds, 600 units. And I think that's absolutely the wrong way to go. Lower and slower is better in the process, for sure.
Well, so it sounds like she's 40 and has 10 or 11 follicles, but at a retrieval will get only 4 to 5 eggs and about 4 mature. So that's just the very same scenario that you're describing.
It is what it is in this business, because really we're counting we should be counting the eggs that are mature as how many you have, but where everyone's so used to looking at like every gamut of this process. But if you just look at everyone's mature eggs and ultimately embryos, you're falling probably into a very normal range. I've seen people bump the dose and get more follicles, get more eggs, but they got the same number of embryos.
Amber asks about deciding between doing a day 3 or a day 5 breast transfer. How do you counsel folks?
Well, I generally say if you have 4 or fewer embryos, that eggs that fertilize, do a day 3. If you have 5 or more, go to blast. If you're doing PGS testing, go to blast. If a previous cycle you had 8 beautiful fertilized eggs and they look great on day 3, but you had no or very few blasts, do a day 3 the next time. So it's not an exact science. You'll never go wrong with the day 3, but you may lose your embryos going to blast. Now, again, a blast may do better because they made it there. But I believe that many embryos, had they been transferred into the uterus on day 3, equally or better may become the baby in your arms, because the IVF laboratories are still not perfect and our ability to culture embryos is still not perfect.
Yeah, for sure. Hey, Ice asked the question in general kind of about transferring more than one embryo. So how do you approach that?
Well, I typically recommend hold on one second, please forgive me. So I generally recommend one embryo. If you're over 35 with the day 3 untested, obviously 2 is not unreasonable. But if you're saying I only want one baby, do one. We really recommend the one embryo. If you have a PGS tested embryo, then 1 is still the recommended number. There may be some cases where you failed with 1 and you're going to do 2. Individually, we'll look at your embryos, we'll look at your story, and we'll help you in deciding which way is the best way. But in general, 1 is the best way to proceed with this.
Okay, there was a question back here, and I'm trying to find what her name was, but it had to do with embryo donation from identical twins. First of all, very confusing for the staff when you check in. They're not going to know which of you is which, and about embryo donation, or I'm sorry, egg donation in general from let's say known donors. Egg donation from known donors or from family.
Oh, all day long. If you can bring a friend, a neighbor, a relative with an egg donor, a sperm donor, an embryo donor, or a gestational carrier, plus we just need more of all of that. So if you have someone or you meet someone at the market and, hey, would you like to do this? I always say ask and you shall be given. But we do a tremendous number of egg, sperm, embryo donations and carriers within family and friends. So we're supportive of that for sure. And we're also supportive of anonymous, and whatever we can do to help build this, we need to do better for all of us.
Valen asks about something that we call an antral follicle count. Now, some people rely a lot on these AFCs or antral follicle counts, and I don't think we do as much, but she had an antral follicle count of 20, but later only gets 4 eggs. Talk to us about how that evolves.
Well, that comes back to the same problem. If you're polycystic or you have a large number of cysts in the ovary, I go back to what's the cause of your infertility. IVF, everyone thinks I'm going to take these drugs, I'm going to get 20 eggs and I'm going to get 20 embryos, but that's just not the norm, because there's something going on that you might not even know about. Hey, my husband had a vasectomy, we're doing IVF, a PESA, and I'm 34, my AMH is good, I have 20 follicles, but for whatever reason, you may still only get 10 eggs and 4 mature in this process and 2 fertilized. This is the mystery, but it's internal to the blood flow, the temperature, the inflammation, that's all flowing through our bodies, and it's flowing through the ovaries also. And so these little microscopic or very small follicles, which are the future eggs to be created and ovulated, we don't know what's in there. No one does. Why is Why do we not have 5 or 6 litters, or why isn't the standard to have 10 to 20 babies? It's because there's a lot of diseases and conditions that are going on to affect all of this. So these drugs, I could put you on 900 units and I still may only get 10 eggs and 3 mature in this process. That's the $1 million question. But we look at antral follicle count as sort of a guideline on, am I going to give you a 300 to 600 dosing or a 100 to 200 dosing? More and more, we're finding still the lower doses work great anyway.
Hi to Oksana, glad to have you with us. Oksana had a friend who wanted to be an egg donor, but was told that we are not accepting egg donors right now, and I didn't know about that. But is that true?
It's not. We accept egg donors all day long, so there must have been something about the donor. But absolutely, get online, sign up for it. If you're bringing your own donor, we are here to accept. Now, there might have been some specifics that would have made her not favorable for you or us, but in general, we are accepting egg donors.
And actually, you mentioned something important there. For you or for us, meaning to say we do have an egg donor bank, right?
We have an egg donor bank, but we also use eggs from other banks all over the country and the world, as long as they're in New York State certified. But we have Colorado, and we're going to, again, have Sarasota and Atlanta later this year, that you can bring your egg donors from other egg banks for sure. But we do have an egg bank. What we love to do today is collect eggs fresh, fertilize them with sperm in-house that you've shipped or frozen at one of our locations, or bring it fresh, make the embryos, freeze them, and then plan a frozen embryo transfer or ship them to wherever you are in this world to allow you to be able to do that.
Well, she says that they just told her that they don't need egg donors anymore, and I'm highly suspicious about that.
Well, so, again, Oksana, bring that back. Send it to our kiltz at See My Fertility. I'll take a look at it, and we'll see what we could do in that. But we may have more of one. We need women of color for sure. And if you want to share some eggs with someone, you need IVF, you're young, you're in the age group, under 30 is always better, under 32, and especially tubal ligations. We're in need of young women who want to help donate eggs, help other women build their families at the same time.
Well, speaking of donor eggs, hi to Rose. Glad to have you with us today. Rose has had 3 miscarriages, and gosh, that's a tough one to have to go through. Her AMH is 0.32, and she has decided to use donor egg. And she's asking about chances of success, and do you believe that her chances are much higher, not knowing any other causes of infertility? So using donor egg to decrease the risk of recurrent pregnancy loss.
Well, if you're older and or have a lower AMH and you fail, donor eggs will improve your odds because it's more likely an egg issue. But don't negate the fact that there's a lot of inflammation, and look at our reproductive immunology site on our website. But reducing inflammation will help tremendously. So just because you use donor eggs, don't negate the fact that you should be looking at laparoscopy, hysteroscopy, or the medical treatment or endo, along with the antihistamine, antimicrobial. All of these things are very, very important and critical, I think, for sure. But because there was another question, I mean, the same thing is on these repetitive losses that the recurrent pregnancy losses, failed IVF or failed IUI or they're all the same problems. It's all inflammation that affects the egg, the sperm, the embryo, and the uterine environment. So we need to approach this with a blanket approach in order to maximize success for sure.
Here's a question, and it looks like there's a few people who have run into this, that Preconception labs were uploaded before the consult, was told during the consult that the Preconception labs weren't looked at. I guess that means that they hadn't been reviewed prior to the consult. I know when I do a consult, if there's labs there, I usually try to go through them right at that very moment. It doesn't make sense for me to review them, weeks ahead of time, because there's just so many folks going through. We want to be, most fresh with them. But
the consult time is the time to review these things then. And that's when we do it. Okay. So we have plenty of time to review these labs. Sometimes we get 100 pages of reports. To me, your history is the most important thing to the story in order to define and help you get to the next level. If you've had the preconception testing, we will review it right then and there.
Hey, by the way, Rose is going to, she's on an autoimmune protocol now, which I think is a brilliant choice given that history. And she's doing her transfer in 2 weeks. So we'll count down and keep our fingers crossed for you. Elizabeth is asking about an HSD, the dye test that people often have, and wonders, gosh, I'm planning to do IVF, and I had a normal saline ultrasound, a saline sonogram. The HSD is expensive. It's far away. Is it necessary? Where does the HSG play a role?
I think hysterosalpingograms to evaluate flush the tubes and a saline sonogram are both helpful. If a laparoscopy, hysteroscopy is helpful also. So these are all helpful in the process for sure. I think I've seen people find out they had a hydrosalpinx, but they didn't know it. You go ahead and you do the HSG and you find that out. I've seen people do the HSG, bingo, they get pregnant. Something different about that procedure, I think, that really, really helps.
Well, so it's both diagnostic and therapeutic. Is that right?
Yes, absolutely. Everything we do, even IVF, is both therapeutic to help you get pregnant and diagnostic. And by the way, Mia White, we do look at the records at the appropriate time and if there's appropriate question to answer. But there's so many things everyone does. And what we're doing is we're putting our light on what you're doing and where you're going. We'd be glad to spend another half an hour to review your records if there's something specific you want to do, for sure. So you can welcome to email me at rkiltz@CNY Fertility, and I'd be glad to set up a time to review those with you. And listen, when it's not working, when we're doing it and you've been failed other places, it's time to have another review, and I'd be glad to do that with you, by the way.
Absolutely right. Oksana, there again, thanks for bringing up that about your friend and her donor, and you're a good soul there. There's a question about metformin in folks who don't have polycystic ovarian syndrome. And when the question was asked, I said, I bet you that was somebody with Dr. Corley. And then she said, that was Dr. Corley. I know Dr. Corley feels very fondly for metformin and what it does for people. What does it do for people? What is metformin, and why do you use it, Dr. Kiltz?
Well, I don't love metformin. I think it's a lousy drug. I think keto is king. It's kick-ass amazing. I think low-dose naltrexone, inositol, or ovasitol are better. But if you're going to do metformin, again, we're not treating diabetes. If you have diabetes, a whole nother story. But I recommend the 500 milligrams at the most, and I see a lot of people do well on that. When it's too much stomach upset, diarrhea, all sorts of craziness, I don't like it. That's my opinion.
And I have to agree. But everybody has a different little approach to things, and some of these interventions are mild enough that they're fine, and so it's kind of a different way to paint a picture. So I don't think there's any harm there. Let's see. An HCG wash. Ulitz is asking about. Oh, sorry, Dr. Kiltz, you want to?
Oh yeah. I just got another question back on day 3 for embryos arrest. Why are they from Anissa? And it's Anissa. It's either an egg or sperm issue, but this is where I recommend the day 3 freeze and transfer. The arresting on day 3 and not going to blast is an issue that we should put them in earlier. Plus, remember the immune protocols, laparoscopy, hysteroscopy, all of these things are very critical, but everyone's waiting. Gee, you don't make blasts. I'm sorry. You gotta freeze them or transfer them earlier, but you really have to look at a more aggressive immune protocol, by the way. What was your question? We've got a couple more minutes here. Dr. Fink.
Oh, yeah, we sure do. My gosh, we're having such a good time. The time has really flown right past here, CNY Nation. So let's see if we can just throw a couple more questions in here. The HCG wash is something that we do pretty routinely, and Yalitza is doing her first time with the stim. Do you feel like it helps? And I think the answer to that is yes. Tell us why.
None of us know the one thing that's going to make it happen. And so a lot of these little things may be it. HCG wash, PRP wash, Neupogen wash. Then there's the booster HCGs. Like anything else, and then there's the Lupron. I think it's a 4 milligram, the Lupron trigger at transfer, which we really haven't talked very much about it. It may be the 1 milligram, but it's another Lupron trigger. But all these things enhance implantation. Why and how, I don't know, but I know they do.
All right. Well, you know what, folks? I think we probably, let's see if we can just throw one more
44 years
here.
young can use their own eggs. Look at our stuff in our family building guide. You'll find some really helpful things there.
That was the one that we needed to close this day. CNY Nation, Gus, we're so happy to have you with us, and thanks to everybody, not only for being here, but for all the love that you're giving to each other, for all the helpful information that you're willing to share, because that really shows that we as a humanity and that we as the CNY family are really here to look out for one another. And God bless you all. It's really a very, very special thing to see here. So join us on Facebook Live, really, I believe, every day of the week. Dr. Kiltz is back on his Sunday morning house call.
Sunday morning, 10 a.m. Eastern time. And if you go to our family building guide, we have a whole host of other practitioners sharing helpful hints and improving your fertility. There's so many really great other reproductive endocrinologists, immunologists, chiropractors, naturopaths that are sharing a story to help you on this journey. Don't give up. It's a frustrating process, but use faith over facts and spirit over science any day of the week. And so thank you, Dr. Fink, and thank you to everyone. Sorry we didn't get to all the questions, but more to come on Sunday and beyond.
God bless you all. Be well.
God bless everyone. Thanks.